Welcome to ZMSC offline and online platform. Today our seminar about cardiac physiology. In this seminar we will cover all about that and diastolic volume and systolic volume, systolic blood pressure, diastolic blood pressure, stroke volume, ejection fraction, cardiac output, pulse pressure, total pressure system, mean arterial pressure, preload, afterload, contractility and heart rate. So let's start about first heart volumes. Here is the two important heart volume regarding cardiac physiology. One is a end diastolic volume and second one is a end systolic volume. End diastolic volume is a volume of the blood at which the ventricle and their diastole, and end diastolic volume also known as preload. Here is only two words. Remember, filling completed and filling completed of the ventricles and contraction beginning and filling complete. In healthy person, end diastolic volume is 140 ml. And here's one important MCQs. As I already told about, end diastolic volume is also known as preload, and preload is decreased by vasodilator known as for example nitroglycerin. Next is the end systolic volume, and systolic volume is a amount of blood which is still remain in the ventricle after completing systole. And here's two words only. Remember, emptying completed of the ventricles and relaxation beginning. Next, some important terms regarding cardiac physiology. First is the stroke volume. Stroke volume is the amount of blood ejected per beat during the contractility. Stroke volume is equal to end diastolic volume minus end systolic volume. End diastolic volume is a larger volume, is a 140 ml, and end systolic volume is a 70 ml. And stroke volume is equal to 140 ml minus 170 ml. Stroke volume is equal to 70 ml per each beat. Next is ejection fraction. Ejection fraction simply called EF and is equal to stroke volume divided by end systolic volume. Ejection fraction is a blood push out by the left ventricle with each heartbeat. Normal ejection fraction is equal to stroke volume divided by end systolic volume. For example, ejection fraction is equal to stroke volume is 70 ml divided by end systolic volume 140 ml, and his ejection fraction is equal to 0.5. when the multiplied by the 100, ejection fraction is equal to 50%, and normal ejection fraction is 50% and 60. Third one is a cardiac output, and cardiac output is equal to stroke volume multiply heart rate, and stroke volume is equal to stroke volume. For example, cardiac output is equal to stroke volume multiply heart rate. Cardiac output is equal to stroke volume is a 70 ml multiply heart rate normal is 72. Cardiac output is equal to 5040 ml. Its main cardiac output is approximately 5 liter. So amount of blood ejected by the both ventricle in 1 minute or 60 seconds is known as cardiac. Next important term is venous return. Venous return, blood return to the left ventricles. Venous return should be equal to the cardiac output. And most important term is a total peripheral resistance, TPR. And TPR is a resistance to blood flow from peripheral structure, for example organs of the bodies and arteries of the bodies. And this is the two important terms. Vasoconstriction or peripheral artery constriction lead to the increased TPR, total peripheral resistance, and vasodilators, for example nitrates, nitroglycerin, is a decrease to the TPR. And here is the most important two terminal blood pressure terms regarding, for example, one is a systolic blood pressure and second is the diastolic blood pressure. Systolic blood pressure is the pressure of the blood in the aorta when heart is in a state of the systole, and systolic blood pressure is largely determined by the stroke volume. And diastolic blood blood pressure is a pressure of the blood in the aorta when the heart is in the relaxed state. Okay, and diastolic blood pressure is largely determined by the total peripheral resistance. Systolic blood pressure is normally 120 mm per mercury and diastolic blood pressure is 80 mm per. Next is most important pulse pressure, and pulse pressure is a difference between systolic PP and systolic PP. For example, systolic PP is a 120 and systolic PP is a 80, and then the PP is a 40. It's okay. And pulse pressure is a difference between systolic and systolic PP. Pulse pressure, most important determinants of the pulse pressure is the stroke volume. Normally pulse pressure is 40, and here remembers most important points. Pulse pressure is increase, pulse pressure is increase, pulse pressure is increase in hyperparathyroidism condition, in aortic regurgitation, aortic stiffening, and obstructive sleep apnea. And next is anemia and exercise. Pulse pressure is a decrease in aortic stenosis, cardiogenic shock, cardiac tamponade, advanced heart failure. Pulse pressure directly proportional to stroke volume and inversely proportional to arterial compliance. His pulse pressure is directly proportional to stroke volume and inversely proportional to arterial pressure. Mean arterial pressure is a diastolic BP plus 1/3, and difference between a systolic BP and systolic BP. For example, here is a map. Mean arterial pressure and diastolic pressure is 80 and 1/3. Then systolic blood pressure and diastolic blood pressure is difference is 40, and after calculation around about 93.3 mean arterial pressure. And next is most important physiology parameter is the cardiac output, and cardiac output must be raised to meet demands. And more cardiac output, more work up by the heart, and more oxygen needed by the heart. Cardiac output is equal to the stroke volume multiplied heart rate. More beats per minute, more work heart, more volume per beat, more work by heart, and more need to. Here is the 4 classical determinants of the cardiac output. One is a preload, afterload, contractility, and heart rate. Now we are discuss by one these parameters. First is a preload. Amount of the blood loaded into left ventricle. For example, here is the left ventricle, and here is blood which come to goes through the enter into left ventricle. This is a preload. Also, how much stretch is on fiber before to the contraction. Before contraction, how much blood is came, this is a preload. And how much fiber of the ventricle is stretch. In some books says length instead of stretch, so this is a this also remember. More preload, more cardiac output, more preload, more work by the heart, and more need to oxygen. Most important point in preload increase by the 3 parameters, and one is a add volume. For example, blood transfusions in someone, and intravenous fluid transfusions. Next is a slow heart rate. Definitely when the slow heart rate, more time for the fillings and more volumes. And third one is a constrict veins. For example, veins force blood into the heart. Veins hold large volumes and respond to blood to the. Okay, this concept is like that. For example, vasoconstriction. When lead to the vasoconstriction, then the venous return is increased. When the venous return is increased, then increase the preload. And here's most important concept regarding physiology: sympathetic stimulation. In body, sympathetic stimulation activate to the alpha-1 receptor, which is already present on the vessels. When alpha-1 receptor activated, then lead to the vasoconstriction. By vasoconstriction, increase the venous return. When increase venous return, then increase the preload. But MCQs here: vasodilator, it decrease the preload. For example, nitroglycerin. When we will give the vasodilator, for example nitroglycerin, and then blood pull in the vessels, then decrease the venous return and decrease the preload. Decrease preload by the 3 parameters: remove the blood, for example bleedings, dehydrations, raise heart rate. For example, when we decrease the heart rate, increase the heart rate, then the filling time in the left ventricle is a decrease, and volume will be the decrease, preload will be the decrease. Third one is a pool in the pool blood in the veins. For example, we give the vasodilators. When we give the vasodilator, blood will stream more and more in the periphery, then decrease the venous trend and decrease the preload. And pool blood in the veins is a mechanism of actions of nitrates or nitroglycerins. Lower preload, less work for the heart, decrease, and this is most important in the relief to the angina. Therefore, in angina we give nitroglycerin. Next, two more important terms regarding preload. One is left ventricle and systolic volume. Left ventricle and systolic volume is the volume of the blood in the left ventricle when heart completed filling phase, and left ventricle and systolic volume is a more harder to measure. Measure as compared to left ventricle and systolic pressure. So left ventricle and systolic pressure in the left ventricle when heart completed filling phase, and more clinically use this phase. So after preload, the term is afterload. Afterload, force resisting flow out of the left ventricle. Left ventricle heart must squeeze to increase pressure in the left ventricle, need to open aortic valves, push blood into aorta. So this mechanism harder to do if blood pressure is high, aortic valve is stiff or stenosis, something in a way, for example, hypertrophy, cardiomyopathy, subaortic membrane obstruction flow of the blood, and blood pressure is a determinant of the afterload. So listen here. For example, here is a left ventricle and here is a, for example, aortic valve and and someone suffer by the aortic stiffness, and when if left ventricle want to eject the blood from the from this area, then lead to the more force because already in front aortic already patient suffer by the aortic stenosis. So simple afterload is a increase pressure against arterial pressure, increase force against arterial resistance. This is called afterload. In blood pressure already more resistant in the peripheral, so when then left ventricle lead to more pressures against the arterial resistance. So this is harder, and then after something, for example, hypertrophy, cardiomyopathy, this is also one of the parameter for harder to do if for the afterload. So afterload increase by raise mean blood pressure, obstruct outflow of the left ventricle, for example aortic stenosis, and hypertrophic cardiomyopathy, and the blood pressure is a major determinant of the afterload. Decrease afterload by lower the mean blood pressure, definitely treat to aortic valve disease, aortic stenosis, and hypertrophic cardiomyopathy. More afterload, more work heart, and more oxygen required by heart. Arterial vasodilator lead to decrease of afterload, for example hydrolyzine. This is a MCQs, and second is AC inhibitors. AC inhibitors and angiotensin receptor blockers decrease both preload and afterload. Next parameter is a contractility. Contractility is a how hard the heart muscle squeeze. Ejection fraction is index of contractility. When ejection fraction is increased, it's mean left ventricle contract more. Major regulator is a physiologically sympathetic nervous system, also increase heart rate. Increase ejection fraction mean left ventricle contract more. Contractility increased by sympathetic nervous system, physiologically sympathetic innervation to the heart already. Circulating catecholamines, epinephrine, non-epinephrine, increase calcium release from the sarcoplasmic reticulum, triggered by stress or exercise. Sympathomimetic drugs, dopamine, dopamine, epinephrine, non-epinephrine, digoxin inhibit sodium potassium ATPase pump, increase calcium in the myocyte. So listen here. Sympathetic nervous system activity. Catecholamines, sympathetic nervous system activity here, sympathetic nervous innervation to the heart. Circulating catecholamines, when the catecholamines stimulate to the beta 1 receptors which is already present on the heart when then result adenyl cyclase will activate, play role in the conversion of ATP into cyclic AMP. Cyclic AMP will activate to protein kinase A lead to the phosphorylation, and in the resultant phosphorylation lead to the opening of the sodium channel, calcium channels, and potassium channels. After opening of the sodium channel, sodium will be influx, calcium will influx, and potassium channels close. Resultant increase sodium in the inside the cell, increase calcium inside the cell lead to the positivity inside the cells, and increase calcium in the cells also increase to the release of calcium from the sarcoplasmic reticulum. This phenomena is called calcium induced calcium release, and increase intracellular calcium lead to the contractility of the. This is very important phenomena. So next is decrease extracellular sodium, decrease activity of the sodium calcium exchanger lead to increase contractility of the heart. One is more important concept is when increase cyclic AMP activate to the protein kinase A. To activate protein kinase lead to the phospholamine phosphorylation will activate ATPase and increase calcium storage in the sarcoplasmic reticulum. This is also important phenomenon. Sympathomimetic drugs, dopamine, dopamine, epinephrine, norepinephrine can increase the contractility. Digoxin inhibit sodium potassium ATPase pump and increase calcium in the myocytes. When digoxin block to the sodium potassium ATPase, increase the intracellular sodium, decrease the sodium calcium exchange activity, increase the intracellular calcium, and increase the contractility of the. All stimulate to sympathetic nervous sympathetic system in the heart, increase the decrease contractility. Sympathetic nervous system blocking drugs, beta blockers, calcium channel blockers, verapamil. This is a MCQ. Verapamil diltiazem, less calcium for muscle contraction, heart failure, especially systolic heart failure, disease of the myocyte can decrease the contraction. Fourth parameter is a heart rate. Heart rate increase cardiac output under physiological conditions. Heart rate mainly regulated by sympathetic nervous system physiologically. Also increased by sympathomimetic drugs. Heart rate decreased by beta blockers and calcium blockers. Here is very two important point and also confusing point. Heart rate. Heart rate increase, decrease stroke volume. Heart rate increased cardiac output. What is this? Here is an important concept. Heart rate sympathetic when sympathetic nervous system physiologically increase the heart rate, increase the contractility. Physiologically increase the heart rate, increase the contractility, stroke volume rise when increase the heart rate. Okay, in physiologically, but in pathologically increase the heart rate, decrease the cardiac output. High heart rate with arrhythmia, for example with arrhythmia is a abnormality can lead to the decreased cardiac output. For example, because why? Because when physiologically sympathetic nervous system increase the heart rate, increase the contractility, increase the filling of the ventricle, increase the stroke volume with the increase heart rate. But in pathological arrhythmias decrease the time to filling for the left ventricle, decrease the cardiac output, decrease the cardiac output. So here is the diagrams. Increase heart rate, decrease stroke volume, less filling times. This is a pathologically increase heart rate, increase cardiac output. This is a physiology. Cardiac output is equal to stroke volume multiply heart rate. Stroke volume multiply heart rate. Next is the myocardial oxygen demand. Preload myocardial oxygen demand increased by the preload, afterload, contractility, heart rate. So this is all about the cardiac physiology, important terminologies. Thanks for take care of your this channels. Like, share, and subscribe with fellow friends. Thank you.